Quorum, and I'm calling the meeting to order. J'aimerais vous souhaiter la bienvenue à la 9e rencontre du comité mixte.
I'd like to welcome you to the 9th meeting of the Special Joint Committee on Physician-Assisted Dying.
From Nova Scotia and co-chair of this committee, along with my co-chair, Mr. Don Oliphant, a member of Parliament for Don Valley West. In today's session, we have two panels. We have the Canadian Cancer Society, represented by Gabriel Miller and Kelly Masati, and we have appearing by video conference from the First Nations University of Canada, Carrie Bourassa, who's Professor Indigenous Health Studies. Now, because of technology, I always invite the video conference contributor to go first, and I would remind you that Ms. Bourassa, you will have 10 minutes, and Mr. Miller, Ms. Masati, you have 10 minutes together in total for your presentations. And with that, Ms. Bourassa, I invite you to make your presentation.
Miigwech, thank you very much. I don't have a very long presentation. I doubt it will take 10 minutes. I want to thank you for this opportunity to present. I'm sorry I couldn't be there in person today. I just wanted to start out with a few points, mainly around the health and history of Indigenous people. I'm sure that these are things you already know, but I wanted to say for the record, for Indigenous people, given our history and range of health and socioeconomic issues, our age and vulnerabilities are broad. Indigenous people have the highest suicide rates in Canada, with Indigenous young women having had the highest suicide rates in Canada at nearly 8 times the national average. First Nations people continue to suffer from high rates of chronic and infectious disease and higher mortality and infant mortality rates compared to the general Canadian population. Cardiovascular disease, diabetes, obesity, cancer, stroke, suicide, motor vehicle accidents, and homicide are the major causes of death among Indigenous populations. Preventable deaths due to circulatory diseases account for 23% of all deaths, and injury account for 22% of all deaths. That is almost 50% of all deaths in our population. For First Nations, ages 1 to 44, the most common cause of death was injury and poisoning, and the primary cause of death for children less than 10 years was classified as unintentional or accidents. The potential years of lost life from injury alone was more than all other causes of death and was almost 3.5 times that of the general Canadian population. Consultations with Indigenous communities across Canada need to take place with regard to physician-assisted dying. While I have engaged and worked with several different Indigenous communities, and I myself am Indigenous, I cannot speak for them. And further, taking a pan-Indigenous approach to policy is not a good idea, given the sensitive nature of this subject and the diversity of Indigenous people and belief systems. The issue of physician-assisted dying is not one that is taking place in communities, and as noted, true engagement and communication surrounding this sensitive issue is necessary, and any legislation or policy implemented that affects Indigenous people must not only include us, but be appropriately communicated to us. Healthcare practitioners have an obligation to provide culturally safe care to Indigenous people, and that includes physician-assisted dying, and understanding all sensitivities surrounding this issue. While strides are being made in palliative end-of-life care, there is still much work to be done, and particularly in physician-assisted dying, as this is a very new area to Indigenous people and will require additional training, in my opinion. That's really all I wanted to say. I think that this is, as I had said before, I spent an hour with the committee that went across Canada speaking about spirituality, belief systems. This is really so very new, and communities have not really had a chance to engage and discuss There's no policy around this at any of the national levels, at the AFN, the MNC, or ITK. I think that there are many sensitivities around this issue. And so while I think that certainly I'm honored to be here to perhaps provide some perspectives, I certainly cannot speak for communities. And I know in speaking with some of the community members that I've worked with and some Indigenous physicians, that certainly that is probably the greatest need is community engagement. So I will leave it at that.
Thank you very much. And I will now turn to the Canadian Cancer Society. Please begin your presentation.
Thank you very much, Mr. Chair. Merci, Monsieur le Président. C'est un grand plaisir d'être ici avec
It's a pleasure for me to be here today.
public issues for the Cancer Society here in Ottawa, and I'm joined by my colleague and our Assistant Director, Kelly Mazzotti, today. I'll be delivering our comments, opening comments, but Kelly will be here to help me answer any questions that people may have for us. It's a privilege to be here on behalf of the Cancer Society, which is Canada's largest national health charity. Canada faces no greater health challenge than cancer. 2 in 5 Canadians can expect to develop the disease during their lifetime. 1 out of every 4 of us can expect to die from cancer, making it our #1 cause of death. I want to thank you for inviting us today, and most importantly, thank you for dedicating your time and attention to this important issue. You're wrestling with some of the most difficult questions any parliamentarian could ever confront. Questions about who should be able to seek assistance dying and who should be able to provide it. These are important and urgent questions. However, we're not here to help you answer them. We have neither the expertise nor the authority. But we are here to advise you on a related issue, and that issue is palliative care. Care designed to protect the quality of life of critically ill patients and their families. Any serious conversation about the needs of severely ill Canadians must include palliative care, and any responsible policy on assisted dying must guarantee access to quality palliative care for all Canadians. 3 weeks ago, we released a new report entitled Right to Care, Palliative Care for All Canadians. The report found that due to serious gaps in palliative care across the country, thousands of critically ill Canadians are not receiving proper care. And that's hurting patients and families, and it's increasing healthcare costs. In the absence of clear national standards and accountabilities, individual provinces and territories and health regions are left to develop their own policies, programs, and guidelines, which is resulting in inconsistent and inadequate palliative care in many parts of the country. In Ontario, 40% of cancer patients do not receive a palliative care assessment in the last year of life. In some regions of Atlantic and Western Canada, less than half of people who die in hospital receive palliative care. Often, palliative care can be provided most effectively and affordably outside of hospitals, yet 1 of every 2 Canadian cancer deaths occur in acute care hospitals, despite the preference of most patients to die at home. By global standards, Canada does a poor job providing affordable end-of-life care, ranking 27th in a recent comparison of 40 countries. By expanding home care and improving support for caregivers, Canada can reduce hospital costs while protecting families from the potentially crippling financial burden of a critical illness. A costly and confusing system that is failing too many patients. That's what our report found. But you don't need to take our word for it. This is an area where parliamentarians have done some outstanding work over the years, and as the Federal Panel on Assisted Dying pointed out in their report, the Senate published studies on palliative care in 1995, 2000, 2005, and 2010. In addition, there are the findings of the federal and provincial panels. And the issue of palliative care and end-of-life care was touched on importantly in the Romano report on health care. Going back to 2000, the report led by Senator Sharon Carstairs found that palliative care is often based on the luck of the draw rather than a basic entitlement of Canadians. It found palliative care was currently provided in hospitals, long-term care facilities, and hospices, as well as through home care, and that when it was provided in hospital, it was fully publicly covered, but then when it was provided at home, only some services and some drugs were covered, depending on the territory, province, or region. The Romano report found there are considerable disparities in access to palliative care across the country, and that these services have been developed on an ad hoc basis and are limited by the financial capability of communities and charitable organizations. Consequently, many Canadians did not have access to palliative care. The roots of this issue is that only medically necessary hospital services are currently insured under the Canada Health Act, with additional care and services paid for through provincial programs and private insurers and by patients and families themselves. This complex and piecemeal funding is particularly problematic for palliative care, which often can and should be delivered outside of a hospital setting. Other contributing factors include a lack of national standards and data collection, insufficient training for healthcare providers, insufficient information and support for patients, and inadequate investment in palliative care services. How do we fix this? We need to begin by making palliative care a top priority for federal and provincial governments as they craft a new health accord over the coming year. Specifically, we are calling on both federal and provincial governments to enact new legislation guaranteeing universal access to palliative care, to expand palliative care generally and home-based services in particular, to increase support for patients and family caregivers, to develop and implement national palliative care standards, and to increase training for healthcare providers in palliative care. Palliative care doesn't have the same complexity as assisted dying. It is simply the notion that people should be well cared for as people to minimize their suffering and maximize their enjoyment of life. The only enduring mystery is how Canada has failed for so long to fix its broken palliative care system. Canadians believe in the right of all people to access reliable, affordable, high-quality medical care. Palliative care is necessary, and the need will only grow more urgent as our population grows older and larger. It's time to recognize the right to palliative care and build a health system that delivers it. Thank you very much. Merci beaucoup.
Thank you. We'll now turn to questions, and for the benefit of the witnesses, each member of the committee has 5 minutes. That includes the time of the question and the response. And because we have a video conference, I would ask members of the committee to make sure they direct their question, identify the individual that you want the question to go to. And so with that, Mr. Alday.
Great, thank you. I'm going to start, Professor Bourassa, with some questions for you, just so you know that that's where I'm going to be aiming the first bit of questioning. I fully appreciate your comments about not being able to speak for the diversity of communities that we find within the Indigenous populations of Canada. It is extremely diverse, and I realize one person can't simply represent those. But I would like your thoughts, or if you can direct us on perhaps pitfalls to avoid, or some of the types of discussions that we should be having. And so with that in mind, I've had the chance myself to live in a number of rural and remote areas, including 8 years north of 60. Many Indigenous communities are underserved medically, and part of the Carter decision talks about access. And so as we look at accessibility of physician-assisted dying for those who choose to participate, I'm just wondering if you have any thoughts related to that kind of question of access from what you know of the diversity of Indigenous communities across a range of options in Canada, and if there's any kind of thoughts there that you can make or thoughts you can share on how do we consider this question of access?
That's a great question. As the previous speaker was, I'm sorry, I forgot his name. I apologize. Was speaking. I was agreeing because everything he was saying was applying to Indigenous people as well. Because if you think just about access to end of life and palliative care for Indigenous people, it's even worse, particularly in northern and remote communities. So if you're talking about physician assisted dying, that is I think one of the main issues. You can't account for the diverse beliefs around whether or not physician-assisted dying will be accepted. I mean, that's something I think that it will be the same in Indigenous communities as it will be in broader communities. Some people are going to be accepting of it, and some people will not be. But when it comes to access, it's going to be, I think, similar issues as it is right now to appropriate, and not only appropriate, culturally appropriate end-of-life and palliative care services. Because right now, for Indigenous people, it's not only about access to end-of-life care services, but culturally appropriate end-of-life care services. So when I was referring to training for, physician-assisted dying, that's what I'm referring to is, how are you thinking about the service itself and the training of the physicians? Because people are going to be seeking out culturally safe services, and what would that look like? If we're just getting there around end-of-life and palliative care, how is that going to look like for physician-assisted dying? So it's access, but it's also access around culturally appropriate and culturally safe care, and what that means in those communities. It might look different community to community or region to region, but certainly in end-of-life and palliative care, that's what we're talking about now, is what culturally safe services look like.
Okay. In your comments, you also had talked about vulnerabilities, and I'd like to explore a bit of that. We'll be dealing with when we're looking at culturally sensitive discussions on physician-assisted dying, looking at both on-reserve and off-reserve populations, and trying to understand, what additional vulnerabilities, like you talked about some of the absolutely horrific statistics that the Indigenous populations are faced with concerning life and death already in Canada. One of the reports that I was reading, and it was a summary of people who already access physician-assisted dying in other jurisdictions. In a lot of cases, it was talking about how it's almost a service that I interpreted for the elite. And, so you have a lot of white men with university education and above average incomes who are accepting or taking advantage of physician-assisted dying. And I'm really concerned about, if we want this to be universally accessible, given some of the vulnerabilities of the population, would that be a concern that you would say we should be looking at?
Yeah, I spoke about this, of course, in the first sort of consultation. It is a concern, and the reason it's a concern is because in our population, end-of-life palliative care isn't necessarily for sort of an elderly population. We have multiple deaths in our communities. We have multiple suicides. We have young people that are dying. It's a real issue in our communities where we have a lot of people dying in younger populations, right? And so when you think about physician-assisted dying, you think about what message that might send in a community where you've just had, a number of youth maybe who have committed suicide or have been in motor vehicle accidents. And so it might not be as accepted. It might not be something that is welcomed. And that's where I was speaking to really communicating what physician-assisted dying could mean in communities and really engaging communities around this, because I think if you want it to be accessible, it's going to have to be well communicated, and as you talked about access, who would access that, and where might that make sense to have access to it? Because I could see it being used in cases where we talk about this concept of not wanting someone to die hard, and so if you have a terminally ill patient and they're suffering, I could see a family wanting to access a physician-assisted death, but it would be in a very very particular circumstance, because we don't want someone to suffer and die hard, if you see what I mean. And so there are circumstances where I could see that access being welcomed, and then there are some circumstances where if a community has just suffered, some very tragic losses, I could see that being something that where they would not want anything to do with physician-assisted death. So it's really about context and understanding community and understanding where it would be, something that's acceptable and where it would not be acceptable.
Thank you. Mr. Warlock.
Thank you to the witnesses. I'm going to split my time with Mr. Daltel. First question is to the Canadian Cancer Society, and thank you for your highlights on the importance of palliative care. First question, and just in the interest of time, if you could keep your answers fairly short. You've shared with the importance of palliative care. You've also highlighted the fact that in Canada right now, palliative care is not readily available for a large percentage of the population. We were told by Health Canada 70% of Canadians do not have access to quality health care. The Supreme Court, on the other hand, has said you need, by June the 6th, to provide legislation that permits physician-assisted dying. If palliative care was to be a component of one of the safeguards to ensure that people are giving informed consent, they're actually having their some of the issues that they are causing them to consider hastening their death. Would you think palliative care is a very important component to ensure that there is truly informed consent? And the second part of that question is, then should the decision by the previous Parliament to ensure that we have a national strategy on palliative care, that this change of culture in Canada, that it could start within this legislative requirement that palliative care is offered to people, anyone, and we're not talking a large number, but it would be required to be offered to people that are considering hastening their death. Thank you.
Yeah, based on everything that I've read about this, I think it makes a great deal of sense to say that palliative care needs to be available and that it needs to be an option in any scenario where assisted death is made available. And I would only go a step further to say that I think we need to think of palliative care as something that is provided to every Canadian who is dealing with a life-threatening illness, and that it will be part of their treatment, managing their pain, dealing with their emotional and psychological needs, helping them receive care in the best place possible. Those will all be part of their treatment right through. And then, of course, with particular emphasis when they face end-of-life issues and also when they're confronting the kind of choices that you described.
Thank you.
Mr. Delta.
Thank you, Mr. Chairman. Thank you, Mr. Wawa. Mesdames, Messieurs, soyez les bienvenus dans votre... I will continue in English because my question will be short. We're not here to see if physician-assisted dying is good or not, but to how. That's the main issue that we're talking about today. And the main question is, do you think that the federal government should clearly indicate to the provincial legislature how to deal with that, or do you think that the federal government should let the provincial legislature with their own definition of how to help people at the end of their life?
I believe, and I think I can speak on behalf of the organization on this point, that we need national guarantees in terms of what Canadians can expect to receive in terms of end-of-life care, and a common set of standards and definitions around the terms we're using, so that there is a comparable experience for Canadians, and that what I think Canadians expect, which is that there is universal access to equal services and support, will be guaranteed across the country.
Thank you. Mr. Rankin, I understand you're sharing your time with Madame Sansucci.
No, not necessarily.
Okay, I have it written down.
Thank you. She's been generous with me.
Pardon me.
I would like to, first of all, ask a question of Professor Bourassa from the First Nations University, and thank you very much for your presentation. You talked about the fact that there was no specific policy from leading Indigenous organizations, the AFN and the like, and yet you stress the need for culturally adapted culturally adopted services in this field and in others. I wanted to ask you, from your experience, whether you see a role for traditional Indigenous healers in this exercise of physician-assisted dying constitutional rights. We've heard testimony that nurse practitioners in remote communities may well be able to play a role here, and I'm wondering if you can envisage a role for traditional Indigenous healers.
Yeah, that would definitely be great. The thing is that this is already happening, and maybe not with physician-assisted dying, but it's already happening in healthcare in general in New Zealand. They're recognized. They work alongside physicians and nurse practitioners, and are recognized as any other medical professional. And I think Canada really needs to consider this, and I think it would be, in this particular instance, in this very sensitive issue, would be most welcome, and I think would definitely enhance any kind of experience by Indigenous people, because right now, even in end-of-life palliative care, we're getting to the point now where most hospitals will at least allow an elder or a traditional healer to come in at end of life, and it's not happening in every hospital, but it's happening in most. And I think that we're starting to get to that point where they're maybe not working alongside, physicians, but they're being recognized, and I think we have to get to that point. So I think it would be highly recommended, yes.
Thank you. My next question is to the Canadian Cancer Society. You talked very passionately about the need for improved palliative care in Canada. And given the requirement under the Canada Health Act for comprehensiveness and accessibility, and given the fact it's just not there, I would like your reaction to withholding funds by the federal government under the Canada Health Transfer to those provinces who simply do not step up and provide funding for palliative care. Is that something that you might be prepared to endorse?
I think this is, I saw a similar question put to the minister in the media, and I thought she did a pretty good job of handling the question, so I'll borrow from her. I don't think anyone would want the conversation to begin with sort of ultimatums being issued by one order of government to another on this. Hopefully, there's going to be enough of a sense of common mission, partly as a result of the need to respond to the Supreme Court, but also out of recognition of the need to address this issue, that the provinces and the federal government can come together and agree that as part of the billions that are spent on healthcare, the tens of billions that are spent on healthcare, Canadians deserve a guarantee that they'll receive access to palliative care. I do think that as part of an accountability framework for a new health accord, there need to be targets for palliative care and home care in particular, and that Canadians need to be able to see that in exchange for the money that goes out across the country for health care, what kind of results that are being achieved in their communities compared to the rest of the country.
Mm-hmm. I know you've been reluctant to jump into the physician-assisted dying part of the equation, but I'm going to push you anyway, if I may. This is a requirement of the Constitution. As my colleague has said, we're here to figure out how to implement the court's decision. So given the experience that Canadian Cancer Society has with people suffering, I would presume that you take the position that we ought to be moving forward with doctors, perhaps with a conscientious right not to proceed, but that generally this service ought to be available end of life. I see you nodding. In which case, do you agree that publicly funded healthcare institutions like hospitals and hospices should be required to provide physician-assisted dying on their premises?
I won't speak to the question of where, because I wouldn't be speaking for anyone then except for myself, and that's of no use to you whatsoever, I promise you. But I guess what I would say is that we need to consider, our view is that end-of-life care needs to be considered as medically necessary care. We have a principle in this country that people deserve access to that in virtue of being Canadian and nothing more, including their ability to pay. It seems certainly that as a result of the court's decision, this will now be part of the spectrum of care available to Canadians, and that access to that care should not depend on people's pocketbook.
Okay, thank you.
Thanks very much for your testimony. If I might say, Mr. Miller and Ms. Massotti, that likely every single one of us around this table would agree with you that palliative care is a pretty important aspect of health care in this country, and that there is a continuum in end-of-life care that includes palliative care as well as physician-assisted dying now that the Supreme Court has made this ruling. And there are those who would suggest that parliamentarians, and I have heard this, should consider a separate piece of legislation around national palliative care strategy and program. But I would like to ask you and push you into the physician-assisted dying, if I might. We know that Bill 52 in Quebec has already begun. There was much conversation about it. It's been in effect since December. And I'd like to know if the Quebec Cancer Society has had any kind of feedback, or if your national organization has something to say about how things are proceeding in Quebec.
So I haven't answered your question. I'm not sure it's going to satisfy you, but we'll find out. The Cancer Society in Quebec has had quite a bit to say about the process there. The organization has been very involved in these discussions right along and has expressed strong support for where that process came out. But most importantly, because as part of what the province did, they enacted end-of-life legislation that included a right to palliative care. And that was always the number one priority for our organization on the issue. So, but certainly I think that they felt like they were actively engaged, that a broader view of the needs of Canadians as they approached end of life was seen by the government, and that not only has that right been recognized in legislation, but now the province of Quebec has started identifying some investments to help make the transition to a more home-based and community-based approach to palliative care.
You talked about the complex terminology and misunderstandings about the terminology, definitions and things like that. And I know that I've heard often the confusion in what palliative care does as compared with physician-assisted dying. Mm-hmm. And I'm sure from the point of view of Canadians, there is a good deal of confusion. I wonder how you would respond to that and what you would recommend in terms of education.
Well, thanks for that question. This issue is, I hadn't even been considering the confusion between palliative care and assisted dying. We have confusion within the country just on competing definitions of palliative care. So this is tremendously important because, of course, if we're talking about rights, and we're in the process of defining what all Canadians have a right to in terms of assistance in hastening death, and we also decide that, say, palliative care needs to be in place, well, then we need to have a common definition of what palliative care is across this country. Education is a big part of this, and I think in our report we identified it a few places. One is these issues, and I would defer to any medical professionals in the room who could correct me, but certainly the latest information is these issues still are simply not a big enough part of the education and training of our medical professionals, that for physicians it's a very small part of their overall medical training, taking into account and learning how to meet people's palliative care needs. There are some astounding figures in this report by the federal panel about the number of palliative care specialists in Canada. I mean, the situation is even more challenging than we had found, according to this. So we need to train more people, we need to have more specialists in palliative care, but we also need to train people as members of teams to be more familiar with how to deal with palliative care needs as part of their specialty, whether they're a nurse or a psychotherapist or an oncologist, whoever. That's part one. And then obviously Canadians need to be better educated. There are a variety of ways we can do that, but one thing we need to do is get advanced care planning dramatically increased in this country. Less than half of people who die from cancer have an advanced care plan in Canada. And having an advanced care plan is not just about, under what circumstances should I be revived or resuscitated. It's about really looking forward at the potential progression of your disease and the types of choices you and your family may face. And it's I think our best insurance for people making clear and informed decisions, but also then maximizing the quality of life they have for however much longer they're going to live.
Senator Joyal.
Thank you, Mr. Chair, and I will start first with Professor Bourassa and then Mr. Miller. Professor Bourassa, in the Truth and Reconciliation report, on the section of health in the report, there are specific recommendations that address the responsibility to train doctors and nurses who provide services to the Aboriginal people to the special reality of Aboriginal life condition and the particular details that you have outlined, description that you have outlined in your presentation. What would be your recommendation in relation to physician-assisted death in the context of those two sections of the report? I'm thinking of section 23 and I think section 24 of the report. I bet that you know the report, certainly. I should have asked you not to put you in the uncomfortable position.
No, that's good. I'm glad you're familiar with it. I'm glad you're familiar with it. That's refreshing. I was just looking at it the other day. It is. I'm actually on a grant around aging and dementia, and it is an area, aging, dementia, and end-of-life care is an area where we are sorely lacking in training, and especially in Indigenous people. And I sit on the Royal College of Physicians and Surgeons of Canada, and it's an area, end-of-life care, palliative care in general, is an area where we're lacking in training. I think it is something that has to be priority, and particularly around Indigenous people, and just looking at cultural safety and in general is just such an area. All of it is really a high need. So for the TRC to make the recommendations, and we have those recommendations in hand, we need to not only train more Indigenous people, we need more Indigenous physicians, but we really have to train the physicians we have to understand the reality in Indigenous communities. So it's really twofold. We have a lot of work ahead of us on both sides, if that makes sense.
Thank you. May I, Mr. Chair, Mr. Miller, do I have to understand that since you have no position on physician-assisted dying, that you did not intervene in any of the cases that went to the Canadian court that raised the issue of physician-assisted death?
That's correct.
That's correct.
Yeah.
Can I give you my candid appreciation of that?
Of course.
I'm surprised that a society as important as the Canadian Cancer Society, that I could think all of us around the table have supported at the point in time in your fundraising drive, supporting the benefit auction and whatnot, and the sale of, all kinds of goodies that you put forward on the market, that since cancer is the first cause of death in Canada, and that one can presume that those who will recourse to PAD, to physician-assisted death, will be Canadians, suffering of cancer, that you have no position on that. I find it strange. Mm-hmm. Could you explain me the rationale behind that? Is it the fact that you don't want to scare Canadians about physician-assisted death?
Well,
or donors.
I can only make some observations based. I've only been there for a little while, so I'll play that card to protect myself a little bit on this question.
But be candid like me, you know.
I'll wait till I'm a senator.
Your job is safe, Serge.
From what I have to be honest with you, I think that my best guess, and from what I've seen, is that there was a lot of concern about the potential for the issue to divide people, and I don't think it's as obviously you worry when you count on donations on how your supporters will feel, but I think there was also genuine ambivalence within the organization. And I have to say, one thing that I've been struck by this issue as someone who's fairly new to being immersed in it is, it feels like the country's opinions about it have come around pretty quickly. The conversations that I'm hearing in the city now about this are very much focused on how. And I think 5 or 6 years ago, they were more about if. And so I think, to be honest, the Cancer Society has been going through what a lot of Canadians have been going through, which is making its peace and addressing kind of the questions and misgivings it had about this. I should also say that one thing I've told people is defeating cancer is enough of a day job. We don't have to solve all of the mortal questions of the universe, and we have to leave some stuff for other people to figure out.
Mr. Bruson.
Thank you very much for the frankness of your answer, sir.
I would like to direct my question to Professor Bourassa, if I may. The first one is, one of the discussion topics that we've heard a lot about has been about the question of what is an adult and mature minors, and there are differences across our provinces and in different frameworks for that. From your research with Indigenous health issues, what do you know about how adult might be interpreted in different Indigenous groups across Canada? Are there different ages that are used?
Oh, yeah. There's sometimes, adult is 18, sometimes an adult is 21, sometimes it's, 26. So it's really, really dependent in different regions. It's difficult to sort of say, and sometimes we say you're still a youth when you're 26, which seems crazy to some people, right? It's how could you still be a youth when you're 26? But I was a youth for a long time. I was sad when I wasn't a youth anymore, but it's just, believe me, I've been youth for a long time. But so it just really depends. It's different in different regions, different territories. So it's it really varies. Yeah.
And is there a concept beyond the numerical age? Is there a concept of when a person reaches, we've been using the term mature minors, but an age where a person is assumed to have reached a certain maturity in being able to make decisions? Is there an age, is there that kind of a concept in different cultures you've investigated?
Yeah, so in the Anishinaabe culture that I'm familiar with, that I'm a Anishinaabe Métis. So when we go through your rites of passage, so for my daughter, when she had her first moon time, now it ended up age 12, but around age 12, 13, when they're going through the rites of passage, that's when you say they're starting to make their mature decisions. Now they're still youth, they're still need the love and support of their parents and their community and their cookums and mushums, their grandmothers and grandfathers. But really, that's when they're starting to, as we say, go into the rapids of life, and that's their tough years, their teenage years. But that's when they have to start making their decisions and learning from their mistakes. So you give them what you hope in their younger years, the values. We call them the 7 sacred stones. And you hope that they're going to make those decisions. And it's up to us now to stand on sort of the riverbank and yell words of encouragement, but not get in the river with them. just let them make their way. And that's really when they start to sort of mature and learn, and you have to let them make their mistakes, if that makes sense. So it's usually around those rites of passage.
Is there a point in time when that starts applying to healthcare decisions? Like, we've been talking about 26, 23, and then also first moon time around 12. So.
Yeah. So it would be around then, because you have to start taking care of your body. So as a young woman, now it's your first menstruation. Now you have to start taking care of your body. So now you have to start making those decisions about your body. Your body is as a sacred young woman, or you're as a young man, right? You have to start making those decisions. And now you're of childbearing age. So that's when you have to start making those decisions around your body, your health. Now it varies, obviously, from community to community and nation to nation, but those are the teachings that I was given. And so it doesn't mean that I'm completely void as a mother, that I don't have input, but you want your child to start making those decisions now, because now they're maturing and they have to start to listen to themselves and make those decisions as a young woman or a young man.
Okay.
Mr. Cooper?
Thank you, Mr. Chair. Sharing my time with my colleague, Ms. Harder, my question is to Professor Barassa. In your presentation, you referred to the need for provision for culturally appropriate and culturally safe services, is how you characterized it. And I was wondering if you might be able to elaborate on exactly what that means in the context of euthanasia and assisted suicide.
Well, I think it's going to depend on communities, to be honest with you, but I think the first thing would be for physicians and clinicians to really understand about power and the systemic issues. We have a lot of systemic issues that I think people don't want to acknowledge. And so really, cultural safety is about acknowledging power systems and understanding the ongoing impacts of colonization. And then, knowing that and understanding that means that then you learn about how to engage with communities. And then when you can engage with communities, that's when you can open up those lines of communication to understand what the needs of the community will be around physician-assisted death. And if you can't do that, then it's not going to be a success. You're not going to know what those needs are, and the needs are going to be very different. It's not going to be much different from end of life and palliative care issues, and so because in fact I think it'll be more sensitive. So if physicians are trained around understanding those root cause issues, those deep-seated systemic issues, they're going to be able to open up those lines of communication, because the number one problem that we've had, and nurses have said this to us, is they don't know how to start discussions. They're worried about offending the people they're working with. They don't know enough about them. They don't understand the spiritual needs and aspects. They don't know why they have to smudge, all these kinds of things. If they can understand those things going in, that is going to make that, those lines of communication open, and it's going to create that environment of safety for First Nations people or Métis people or Inuit people that they're working with, and it's going to make their jobs a heck of a lot easier.
Okay, thank you.
So this question is over here, and again, thank you very much for coming out today and for being with us. My question for you is, as an organization, you've clearly taken a very strong stance with regards to palliative care. You've been great advocates on that front, and I'm just wondering if you can explain to me the impact that a lack of palliative care might have on a patient's decision to opt for physician-assisted suicide.
Good question.
Well, why don't I just speak first about what the impact of a lack of palliative care, that impact on any patient, and then we can talk a little bit more about how that might affect someone facing that issue. I mean, palliative care is care that's designed to protect the quality of life of the patient and their family. And it's easy to forget, I think, how much our system is built around delivering services in hospitals that are about typically fighting a particular disease or treating a particular ailment. And that system, left to its own devices, can leave people in a place that's where their pain is not effectively managed, where their symptoms from dehydration to nausea to dementia can become a greater and greater drag on their quality of life and their ability to think clearly, where their despair and their anxiety and their fear in confronting their own mortality or confronting the pain of dealing with severe illness can have a profound effect on their outlook. And of course, on whether they're able to receive care surrounded by loved ones and in a community setting versus sometimes in an emergency room or in an intensive care unit where they can be really removed from the people they need around them. So I think it's intuitive to all of us to see how those factors, how much they could affect someone's well-being, their mindset, and also there's evidence that it actually affects their medical outcomes, that people who receive effective palliative care, especially early palliative care, do better. And, I think we can all understand how having a positive and a healthy outlook and not dealing with depression and anxiety can make it easier to combat a physical challenge. I don't have research or expertise in terms of the connection between that and assisted dying, but I think what's said in the consultation piece that was done by the panel, nobody, and in fact this was a quote from Dying with Dignity, nobody should have to choose an assisted death because the medical system has failed to give them other options. Canadians do not want assisted death to become the preferred option simply because other options such as high-quality palliative care are not accessible. So I think, we need to see that one of the unifying principles in all of this is we would like as much as possible for people to help people overcome their suffering and meet their challenges through care and support. And anyone who chooses death because those things weren't available, that would be a tragedy.
Thank you. Senator Nancy Ruth.
I would like to know what is palliative care. And the reason I'm asking is because I heard recently of a friend whose husband had colon cancer and was in palliative care, and he was effectively starved and not given fluids. His muscles contracted, and it seemed that he was in more pain. And it was an extraordinary story. The whole family suffered, the child, the wife, and so on. So could you tell me what it is you mean by palliative care?
Sure, and I mean, the professor may have more to add or corrections to make in my response. We take a fairly, I would say, a broader view of palliative care in that we really believe that palliative care is something that needs to begin as soon as someone is diagnosed with a critical illness, because palliative care is the care that's focused and preoccupied with the patient's quality of life and their quality of life issues that emerge the moment someone is diagnosed with a critical illness. From that moment, they have to start dealing with a great deal of uncertainty. They need to be engaged in planning their treatment. There may well be symptoms and to manage as a result of early treatment. But of course, these issues become more pressing the closer you come to end of life, because how sacred that time is that you have, but also because those challenges are pressing in on you. More specifically, palliative care is delivered by a team. It is not delivered by a single specialist, and that team could include a palliative care specialist, but it will also include potentially a family physician, psychologist, nurse, a support care worker. All of these people need to be working from the same playbook in terms of the choices that the patient has made in terms of their care planning. And they really focus on three things: pain and symptom management, which gets very complex, as people know, and there are a variety of medications and treatments going on. Second is psychological and emotional support, which, we all know, with the Mental Health Awareness Week that's just happened, we all know what an interaction there is between our mental and physical health. And then the final piece that we like to emphasize is the engagement of the patient in key decisions, including the location of care. And that means patients having the option to receive care in the community or at home when that's medically feasible, which is also usually more affordable for the system.
Were you surprised by the story I just told you, that was what had happened to this particular man in palliative care?
Yes.
All right. Okay. All these criteria you've given, when my own mother was 90 and was told it wasn't worth pumping out her lungs and doing heart work, she was given 3 choices on how to die. And she chose one, and that was it. She was put on a morphine drip, and out she went. There was no food. There was no water. Is that unusual in your experience?
Well, Senator, I really need to be careful because I'm not a physician.
Right. Thank you.
Okay, thank you.
Senator Cowan.
Thank you. The risk of appearing to sort of gang up, I wanted to follow up on some points that Senator Joyal made earlier. All of us are aware of the statistics of the availability of palliative care and the need for better palliative care, more widely distributed across the country. But that's not the issue that we are here to deal with. And we've asked you to come here tonight, or you've asked to come tonight, to help us deal with a very specific issue, and that is how we should advise the government to respond to a decision of the Supreme Court of Canada. And this has to do with assisted dying, not with availability of other things. Now, none of us see palliative care as or that physician-assisted dying to be an alternative to palliative care. None of us see that. But if we look at the international experience with physician-assisted dying, I don't have the numbers in front of me. It seems to me that in every country where they've tracked the numbers and the reports over the years, patients suffering from various kinds of cancers are the highest users of this option. So if that's the case, it really surprises me that the Canadian Cancer Society, which has done so much good work in this area, is not prepared to come and give us some assistance in the task that we have before us. And I think particularly of advance consents and directives. I mean, I know from my own experience as a lawyer, the number of advance directives that I've drafted for clients who have cancer, and they're concerned about the prognosis. So the Cancer Society must have thought about this. And is there no advice you can give us on the specific issues that are before us today? I mean, all of us would, I'm sure, support greater availability of palliative care, but that's not doable. We have to report to the government by the end of this month on some very specific issues. And I was hoping that you might be prepared to provide us with some assistance on those issues tonight.
I appreciate what you're saying, and I think that as this issue moves on, there's no question that there's probably some more thinking we have to do, and to be part of some of those decisions. Certainly, we, I think, recognize that the country's moving forward in this area, and that there's a discussion to be had. And to be honest, I think that having reviewed the consultations that have been had, there's some very good feedback being provided to the committee. I can appreciate your frustration with our not engaging on that question. I think I would only say, and I hope you'll take this in the spirit that it's provided. I think the greatest risk in this situation is that the country will go by through this situation and say, "Oh yes, of course, everyone can agree." And I don't mean to in any way insult you, but oh yes, we can all agree palliative care, but we really need to take care of this assisted dying piece. And I go back to what's listed here in reports in 1995 and in 2000 and 2010. Mr. Albrecht.
But excuse me, I mean, I don't mean to cut you short, but I'm going to get cut short here in a minute.
Sure.
I mean, isn't it exactly that we have to, this committee has been charged with the responsibility. The government has said it will act in response to a specific time frame that's set for it by the Supreme Court of Canada.
Right.
So even if we wanted to, said, well, all right, let's set this issue aside. Let's solve the palliative care issue.
Yes.
And then we'll come back to this.
Mm-hmm.
You
Oh yeah,
with me. We don't have that luxury.
Oh, and Senator, if I've in any way left that impression, I want to correct it. We completely understand that the Parliament has been, a direction's been provided by the court, and that there's work to do on assisted dying, and then a response has to be provided on that. And frankly, we accept the courts that this is now a right that's going to be recognized in Canada, and there's questions about how it's going to be exercised. So this is not a question of wait until. My concern, frankly, is that we will only deal with assisted dying, and I think what we're to say is deal with assisted dying. I'm happy to go back to our society and say these people need some more feedback from us, but it will be a failure and the most dangerous failure if we don't also fix palliative care at this moment.
And I would agree with you, absolutely.
Thank you.
La question va s'adresser à la Société canadienne du cancer.
I have a question for the Canadian Cancer Society, Mr. Miller. I don't want to repeat what Senator Cowan and Senator Joel just said, but initially you stated that you were not here to help the committee to help us resolve what to do under our mandate after the Carter ruling. Very frankly, I'm disappointed in the Canadian Cancer Society, knowing that cancer is one of the leading causes of death in Canada. My question is, are you the spokespeople of the Canadian Cancer Society? Microphone, please.
This is the
I apologize, Mr. Warren. I was getting an issue with the
Thank
clerk.
you. We've invited witnesses, and I'm concerned that we are now criticizing one of the witnesses because they have not got a position. They've shared their position, and now to bait them and insult them, saying that they're very disappointed with this organization that is respected around the country, I think is inappropriate and it's carrying this too far. And so they're here to witness. I'd encourage not to put words in any mouth of any witness, that we respect the witnesses and we show that we do show respect. And I'm concerned that we're going too far when we start criticizing them and saying we're disappointed that they don't have this or that position. Thank you.
Your point is well taken. We are here to get advice with regard to creating advising the government on the legislation, and I would urge us all to stick to that objective.
Oui. Le point que je peux faire, Monsieur le Co-président, c'est que on ne connaît pas la position.
Yes, and the point I want to make is that we're not getting the Canadian Cancer Society opinion about the Carter ruling. I didn't mean to insult the witnesses. I would like to apologize to Mr. Miller if he took it as an insult. But I would like to come back to the fact that you mentioned that thousands of Canadians don't have access to palliative care. I heard a number. I think I read that 70% of Canadians don't have access to palliative care. Is that indeed the situation in Canada? Thank you very much for the question. I will answer in English.
Several different figures. That's the figure that's in the panel's report. Our report has different figures from across the country. I've heard figures as low as 15%. And to be honest, that illustrates the problem.
Pardon me, what would be 15%?
15% of Canadians have access to palliative care.
Only.
So the fact that are in public circulation, there are estimates as low as 15 and up to 50 or 60, is a pretty clear indication that we don't have a good handle in this country on how well palliative care is being provided or at what level in different parts of the country, and in fact that we don't even have a common definition.
Sorry, Mr. Co-Chair, I was interrupted. Do I still have time?
Yes, you do. 2 minutes.
2 minutes. Concernant, Monsieur Miller,
Mr. Miller, with regard to access to statistics, you've also said, I heard such and such. I'd like to ask whether the Canadian Cancer Society has carried out research on the topic of the accessibility of palliative care throughout Canada.
A complete review of all the most recent literature across the country. And the statistics that we cite in ours are because palliative care isn't measured or defined in the same way across the country, you have to sort of gauge access through other indicators. One of the best indicators is how many people are dying in hospital instead of at home. And so almost 1 in 2 cancer patients are dying in hospital, which is an indication that they aren't getting palliative care early enough and not getting the chance to choose where they receive care. We don't have an estimate that we generated ourselves of how many Canadians have access to palliative care. It would take considerable resources to generate such an estimate because first you would need to define it for the whole country and then you would have to go out and collect data. And that's not being done in the same way in different parts of this country right now by anybody.
Thank you. Thank you very much. Okay, this brings us to the end of this session. We've let it go a little bit longer because of the absence of the third panel that we had hoped for. But I do want to thank our guests today. And before I officially close the meeting, I have a couple of notes for committee members. I can advise you that tomorrow's meeting is expected to be as scheduled from 5:30 until 8:30, okay? So it is expected to go as per the schedule. However, for Wednesday and Thursday, there may be votes, and so we will try to adjust the schedule as required. And we will let everyone know as soon as we have confirmation of this, as soon as we have confirmation of the vote issue, and in doing so, we will try to start the meetings earlier, as opposed to going later, okay? And with regard to Friday, I want to remind us that we have 2 meetings in camera, one from 9 to 11, and the second one from 12:30 to 2:30, okay? So that is the schedule as with certain certainties now and certain uncertainties, but the uncertainty will be as to when the meetings start on Wednesday and Thursday. That's it. With that, I declare the meeting adjourned.